Hi there. We're going to finish up Chapter 6, Microscopic Examination of Urine. Let me just get the slideshow started for you guys. We're going to pick up basically right where we just left off in class. These, again, are the learning objectives for the entire chapter. We're focusing today on the actual microscopic examination of urine. You can read those at your leisure. We had talked briefly about microscopy, that the bright field microscope is our most common mechanism for viewing urine sediments in the laboratory. We use a traditional microscope with a 10x and a 40x magnification. And we're going to remember that we're going to use a lot of control with light when we're looking at urinalysis. If the specimen is unstained, which typically they will be. Some labs only use stained urines. In our student lab, we're typically going to use unstained. We will practice with some stain, but we are going to do some without as well. You really have to keep the light source down low. So we're going to use a great microscope that has a rheostat, or that the little thumb wheel that helps turn the light source up and down, and then the condenser that's located underneath the stage that also can be raised up and down to really monitor that light source and keep it down nice and low and get a good differential between the urine component and the fluid background. We tend not to open and close the aperture. That's not really the purpose. We're going to be trying to keep the light source down. We talked briefly that we can use phase contrast, polarizing, other kinds of microscope techniques. Phase is the one that we would typically see in the laboratory again. And phase is just one where it uses a process that in short, splits the light beam that we come up from the light source into two different rays, and they focus differently on the three-dimensional objects within the field. So you get much more contrast because it's able to view the object using, or the light source affects it in different ways and projects differently against the object based on the thickness in different parts. So when you have a 3D object, obviously the light reflects it in different ways and provides a nice contrast for us to be able to view each object. In my lab, we used this mostly for very small things like platelet counts that we had to confirm by microscopy. Because they're so small, it was very easy to visualize them. Polarizing microscopes, we use, and we'll talk about when we start to do body fluids, we use them to identify crystals, especially in body fluids. We may or may not in the urine lab use them as well, but we'll see a couple of photomicrographs in the lecture today that use polarizing scopes, but we're not going to focus on that today. So this, just talked about it. The microscope, we've already talked about this. I just left this in so that we are sort of in the same place. If you need to review this, go back to your textbook. Go back to our lab that we first started at the beginning of the semester, where we looked at the microscope, and also look at your intro modules on the microscopy. All of those things should be able to help you refamiliarize yourself with the microscope. Please make sure that you have spent a little time with this part of the discussion and that you understand the terms and the objectives, as well as the individual parts of the microscope. Color illumination, I left this in mostly just for a quick 2-second discussion, and that really color microscopy is really just providing a mechanism where the light that comes up from the bottom is able to be, it's allowed to reflect the light through the sample, but we don't end up seeing the light source individually within the zone and what we visualize in the microscope. So you end up with this kind of a broad field of being able to examine something without the pinpoint light coming up through the middle. Care of the microscope, we've talked about before, and I know you did this. Please again be familiar with this and make sure that you are very, very comfortable with this. Remember, in urinalysis, we are never using oil for this. We're using only 10 and 40x objectives, so oil should come nowhere near you. You want to make sure, though, because we are using wet solutions, urine, that you may inadvertently get the oil immersion lens into a small drop of urine. We should obviously try not to, but we're always going to make sure we clean the 10x oil lens after a urinalysis procedure. We started talking just briefly about urine sediment constituents. And remember, we're going to look for a rare epithelial cell to help us to focus the microscope when we first are trying to visualize the urine sediment. Lots of things will happen in urine sediment. Cells get distorted in shape and size and inclusions, mostly when it's sitting in urine. And it's sitting there for a period of time. So we have to consider that and take that into consideration. We did speak briefly about red blood cells, but I wanted to keep it here just so that we can have everything on the same slide deck for you. Remember, red blood cells are biconcave, and so part of the difficulty that we see is that there are things that look similar to a red blood cell but don't have that biconcave shape. The first one that we always worry about are those yeast. Here's a yeast with a little bud off of it. Here's one that's not. This one you can see the biconcave. Remember, I drew it on the board and showed you how in the middle it kind of scoops in on the upper and underside, almost like a balloon that's underfilled. And the fluid all goes out to the side. So you can see the little biconcave disc in the middle of a red blood cell. This does have something there, but this is a yeast with buds off of it. You can see these have little buds. We want to be careful. Remember, oil droplets are going to be very shiny. Air droplets are going to be very shiny or refractal, and maybe on a different plane. So if you're focusing, remember to find a cell to focus on, not just on something. Starch is going to be very refractal. Things that don't come from your body are typically going to be very refractal. And I say that in the strangest way because the oil can be included in cells because it's coming from your body, but it's not always. And remember, we're always going to correlate this to the reagent strip. Red blood cells, about 7 micrometers in size. We talked about crenated, those ones that get the little prickly thorns on the outside, and we see those in hyposthenic urines. The water rushes out of the cell, squeezes them up like a raisin, and you get these kind of oddball shapes. Here's a typical red blood cell, nice, round. They can be laying on their side. Remember, red blood cells are 3-dimensional, and so if they have a little bit of an odd, twist or turn to them, it's because they're rolling around in a fluid. So imagine you have a beach ball in the pool and you're rolling it or you throw it in. It rolls and twists and turns. And the same thing happens to red blood cells. So be aware that you don't always get a picture perfect one like this. You might get one that turns a little on its side. But these are the crenated ones. Those are the ones with the little spikes on them. And then we also talked about those ghost cells that we see in hyposthenic, the ones where there's lots of water. Remember, hypersthenic is high specific gravity, so there's lots of stuff in the urine, dissolved solids, and hyposthenic is the ones we see when there's lots of water. And it sort of makes water enter into the cell. They puff up a little. They're going to burst open and leaches out their hemoglobin, and you end up with just a little teeny shell of a red blood cell. These are not, I wouldn't call these ghost cells, frankly. I think that that's what they're trying to say there. Maybe this one, This is a red cell. This is probably a ghost cell here. It's an air bubble and an oil droplet. See how shiny they are? There's a cell, not shiny, oil droplet, shiny. Red blood cells can also look abnormal or dysmorphic inside of a urine. We typically see them in some kind of disease state, things like damage to the glomerulus, where we're getting some bleeding of red blood cells, maybe after some kind of strenuous exercise. Some of the shapes that we can see, and I drew these on the board, the acanthocyte or acanthocytic is a very spiky one, not like the crenated ones where the spikes are all over the cell, but really they're very abnormal spikes. Sometimes we get that blebbing or the little, looks almost like a little bud off of a red blood cell. We might see fragments, we might see things with very little hemoglobin in it. All of these things, these dysmorphic shapes, can help a physician to diagnose it. So if you do see things like acanthocytes in the urine, we'll mention that, as long as that's what your lab's policy is. Normal value of red cells, 0 to 3, up to 5 per high power field. After that, you're really starting to consider that there may be some damage to the kidney, typically to the glomerulus, maybe some vascular injury where red blood cells are seeping out of the vasculature within the genitourinary tract. So different things can cause some damage that allows red cells to be excreted in the urine. We definitely correlate that to the number of cells. The more cells, the worse the damage. And you have to also remember one of the other key things that we worry about with urine, and I think we saw this in lab yesterday, sometimes we'll see it macroscopically. We'll see a very red and cloudy urine. That we're going to consider maybe some advanced renal disease, trauma, some infection, maybe some other blood disorders, where we're spilling over large amounts of red blood cells into the urine, versus microscopic hematuria. Just a couple, the urine looks basically clear. It may have a tinge of pink to it, it may not. But when you go look microscopically, it's, and on the dipstick will show positive for blood. And then you go look microscopically and you're going to see more than the normal number of red blood cells. And that's when we're going to start to consider maybe kidney disease is starting to develop, maybe there's some kind of malignancy. But again, normal things can cause it too. Very, very strenuous exercise. Kidney stones can cause things like that that allows a little bit of blood to enter the urine, but not such a large amount that we see it in our macroscopic analysis of color and clarity. The next cell we're concerned with is white blood cells. These are a little bit less than double the size of red blood cells at 12 micrometers. Here's a red blood cell. I'm assuming, let's say there's a red blood cell. Here's a white blood cell. The white blood cell has more content in it. Remember, the red cell does not have a nucleus in a mature red blood cell, but the white blood cell will. Many white blood cells have some granules in them. Those neutrophils, eosinophils, things like that have granules in them. So there are different kinds of nuclear shapes that we're going to see, as well as granulation. Neutrophils are the most predominant, and really it's because if there's going to be something that's causing neutrophils or leukocytes to spill over into the urine, it's some kind of infection typically. And most infections, we think of neutrophils going along with that. Those are kind of a all-purpose, general purpose infection fighter. So neutrophils, we see them in bacterial infections, and we'll see them in other kinds of infections as well. I showed you the glitter cell. We see those when the urine is very hypotonic, and makes basically the water enters into the cell. Lots of water outside the cell, and again, to make that balance happen, the water enters into the cell, makes the granules inside of the cell swell up, and they have that kind of glittery Brownian movement I talked about. I still can't swear that I know another word for Brownian movement. I think Brownian movement is what it is. It's not a real movement, it's kind of an optical illusion. The granules sparkle, and they will stain. White blood stain kind of a blue when they're stained with in the urine. These are just some examples of white blood cells. This is a good one where you can see the nucleus. This one, do you see one lobe? Two lobes here. This is a neutrophil of some kind. There's at least two lobes. There may be more there. This is a single lobed one. So this may be a monocyte. It may be it's really big for it. Frankly, it's very big. I wouldn't consider that it would normally be a lymph, and it's very granular. But you can see there's the nucleus. If you're trying to determine the difference between a white blood cell and a red blood cell, look for the nucleus. We're going to look and see. These have very distinct nuclear material here. Sometimes we can do this with stain. And if you remember, I talked about in lecture on Tuesday how we can also do this with acetic acid. That will bring out and enhance the nuclear structure. Remember, though, we can't use, number one, we don't add acetic acid directly to the original specimen. We use a small aliquot or sampling of it. Number one, we don't want to destroy the original sample. And number two, we can't do the full microscopic analysis based on that because that acetic acid is going to hemolyze all the red blood cells. We talked briefly about eosinophils. Here's one that's been performed with a Hansel stain. Remember, that's very specific eosinophilic stain. Eosinophils are seen in increased numbers when there may be a drug-induced nephritis or infection in the kidney, and maybe in renal transplant rejections. What we're going to do is we're going to stain the urine. We're going to count anywhere, depends on how many cells there are, between 100 and 500 white blood cells in the urine sediment. So we'd count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. God forbid this could have been 10, so the math would have been easier. Let's pretend that's not there. I'm just going to say there was 10. 2 out of 10 would be 20% eosinophils, right? So if we counted 100 of them, we'd count how many were eosinophils, how many of them were other, for a total of 100 cells and get the percent. The more cells you can do, the better it is, but sometimes you get what you get. But really, anything over 1% becomes clinically significant. Mononuclear cells are things that don't have multiple lobes to their nucleus. They have a single lobe. Those lymphocytes that we see, the viral infections, monocytes, macrophages, histiocytes, all are mononuclear cells. Monocytes, macrophages, and histiocytes, which are rare in the urine, tend to be larger and not quite as round. This one has multi-lobes, so that's a neutrophil. This one, I don't know why that's here. This is not the best picture. None of these would I really call mononuclear cell. Maybe this one. Not the best picture I've ever seen. The issue with mononuclear cells, and we're going to see in a few minutes, the renal tubular epithelial cells, some of the lining cells of the kidney and the bladder and the ureters, we really want to make sure we distinguish between them. So when we see the renal tubular cells, I think you'll understand the difference. So bear that in mind as we continue to go. Lymphocytes can look like red blood cells. We can see them in transplant rejection. If we had any question about what these cells were, what the significance was, we'd send them off to cytology for someone to look. Normal white cells, less than 5 per high power field. Sometimes you can see more in women. Normally, we don't excrete white blood cells in any great numbers, but remember, white cells can enter in through the glomerulus or through trauma. But they also have a process, frankly, they call it amoeboid migration. White blood cells are infection fighters, and they're intentionally designed to be able to leave the blood vasculature and go into tissues. So there's a mechanism for that, and you'll learn that in immunology with me over the summer. So there are ways for white blood cells to get normally into the urine. So we do allow up to 5 is pretty is insignificant. When we start to see higher numbers than that, we're going to call it pyuria. And we are going to consider that it's going to be really infectious, most likely some kind of an infectious disorder, cystitis, pyelonephritis, prostatitis, urethritis, inflammation of those areas individually. Glomerulonephritis is another one. You can see and read through here, all sorts of things can cause you to have pyuria due to some kind of an infection or renal or disorder. Lupus is an autoimmune disease, interstitial nephritis, tumors. Make sure that if you see white blood cells and you see bacteria, we're going to mention that because those two together are going to give us a sense that it's an infection and not a tumor. So I mentioned to you just a moment about about epithelial cells and how important it is to be able to distinguish them from white blood cells. Here's a white blood cell. Here's a white blood cell. You can see the relative size here. There are 3 kinds of epithelial cells, and this is a great picture, that 3 different types: squamous, transitional, and renal tubular. Squamous is generally clinically insignificant. They're these really large epithelial cells, comes from the vagina, the male and female urethra. They're shed normally just during voiding of a urine, and you typically are going to see some in virtually every random or clean catch urine. So we're not going to panic about those, but the good news is because there are usually a few there, it's something great to find and focus on when we're trying to make sure we're in the right plane of the urine for microscopic evaluation. Squamous, they're, and epithelial cells in general, they're bigger and they're usually the first things we're going to see under low power. We're going to also look in just a second at transitional epithelial cells. Transitional cells we see come from the bladder, the renal pelvis, the calces, ureters, and the upper male ureter. This shows a particular shape of transitional epithelial called a caudal cell. We're going to look at that in just a second, but they don't all look like this. This one has like a little tail on it. And this is a renal tubular epithelial. These cells actually come from the renal tubules of the kidney. And if we see those in a urine, they're important that we report them. They're very clinically significant. So white blood cells, but you can see relative size, white cells and renal tubular cells. There's definitely a difference in size. You're more likely to have, even transitional cells are larger. You're more likely, I think, to have a problem between white blood cells and transitional cells than anything else. There's a red cell, white cell, transitional, renal tubular, and squamous. Let's take a look at them in detail. So squamous cells, you can see they're very flat, irregular shaped. They have a very small nucleus here. Largest cell that we typically see in the urine, so in relative size, a red cell and a squamous cell, considerably different. We report these just in kind of a generic mechanism, rare, few, moderate, many, or in some labs, we'll say 0 to 1, 2 to 4. And when we go over the classification in lab, we're going to go over individual classification for our student lab. But remember, the standard operating procedure wherever you go is going to determine how you report these. Again, very normal. It's typically contamination. Squamous epithelial, here's just a couple of examples. This one has been stained, or it may even be some red blood cell staining, some dissolved or hemolyzed red blood cells. I didn't look to see if this was, if the picture itself was a stained one or if it was hemoglobin stained. I should have looked. Just flip into the book. Do I see it? Do I see it? Do I see the definition? Blah, blah, blah. Stained. Yep, this one was stained within the laboratory. But large ones like this. This large clump of epithelial cells. Sometimes you see them in a sheet or a clump. We call that syncytia, and I'll point that word out to you on another slide. I can write it down. And Syncytia, syncytia, means kind of a clump or a kind of a cluster of cells. Clue cells, I'm pointing this out to you. Clue cells are the only time that we really worry about identifying squamous cells as being something pathologic is when we see clue cells. And all clue cells are squamous epithelial cells that are really covered with a specific kind of bacteria that are coccobacillus in shape, and they are typically seen in a infection we call Gardnerella vaginalis. And so it has a coccobacillus species that covers most of the cell, and it actually even extends a little bit beyond the cell. Lots and lots of bacteria on there, and they take on kind of almost again, kind of a layered effect with the squamous and the bacteria on it. So make note if you see that. Clue cells. So the next kind of epithelial cell that we talked about is the transitional epithelial. We call those the urothelial cells because these come from the lining of the ureter, typically the bladder or the kidney. And there are three forms. The spherical, the caudate that I just told you about, or the caudal, and polyhedral. So the spherical is exactly what you imagine. Looks like a sphere. And it does that because the cells take on more water in the bladder. They get big and round and chubby and spherical shaped. Caudate are the ones, or caudal, are the ones that look like they have a tail. The one that I just showed you in the picture that had a round head, round part of the epithelial cell, and then it had a little tail that went to it. And then polyhedral are ones where maybe you can see them with multiple sides. It's important to differentiate transitional epithelial, which are lining cells, versus the renal tubular epithelial. And one of the best ways to determine the difference between them is transitional epithelial typically have a centrally located nucleus. So if we go back to this picture, it's not the best because this is a caudal cell, but the nucleus is centrally located. In the renal, the nucleus is off to the side or eccentric. So typically renal transitional have a centrally located nucleus. Renal tubule have an eccentric nucleus or off to the side. There's that word I told you, syncytia. That just means clumps, and we can sometimes see those in normal conditions. If we see a syncytia or a clump of squamous cells, I'm not going to worry about it. If I see a syncytia of transitional epis, we may consider was the patient catheterized, and that during catheterization they just kind of scraped along the lining of the ureter, or maybe there may even be some malignancy. Here's a couple of examples. There's a syncytia. Do you see how the nucleus is right in the middle? These are kind of those rounded shaped ones. This is those caudal or caudate sides. They have the little tail on them. Renal tubular epithelial, really, there's a couple of different sizes or shapes that we see with this, but renal tubular epithelial cells are always clinically significant. There's the columnar, which we're going to see a picture of in just a second, are kind of rectangular shaped with a little bit of a rounded edge on both ends. We'll look at those in just a second. Columnar renal tubular cells come from the proximal convoluted tubule. If they're round or oval renal cells, we're going to see them that they're developed in and shed from the distal convoluted tubule. And then cuboidal, which we'll see in just a minute, come from the collecting duct. So if we see three or more cuboidal cells together, we call that a renal fragment, and we would report that independently. when we're looking for, these are the ones from the proximal convoluted tubule, the PCT. So these are the columnar, sorry. You can see it has almost a large rectangular shape. It's columnar, it's long and thinner, and then it usually has a little bit of a rounded edge. The difficulty with this is it's often difficult to distinguish this from a cast, which we're going to review in just a minute. You'll see in a few minutes this looks very much like maybe a cellular cast or a granular cast, much harder to distinguish. We're going to take a look at the cast formation. Casts tend to have a very distinct matrix around the edge, and they don't have this kind of irregularity like this. Coarsely granular cytoplasm, and there's the nucleus here. This one happens to be eccentric, so I take it back. This one is eccentric because it's a renal tubular cell. I almost misspoke. This is eccentric, so always notice the nucleus is eccentric on those renal tubular cells. Here's another renal tubular cell, a different one. These are those kind of round or ovally shaped ones from the distal convoluted tubules. Notice that nucleus is off to the side. This one's a little more centrally located, but still off to the side. This one is way off to the side. And as a point of reference, here's a white blood cell. So you can see the difference in size, considerably different. Eccentric nucleus means off to the side. It's not eccentric like, my, crazy old relatives. It's eccentric means off to the side. And then those collecting duct renal tubular epithelial cells are cuboidal, not round. They always have at least one straight side. They also have an eccentric nucleus. Again, these are a little less eccentric. This is a better picture. So here's the cell here, and there's the eccentric nucleus. This is an example of that clumping, that renal fragment that we see sheets of cells coming out. This is clinically significant as well. We only see this in those collecting duct renal tubule epithelial cells, not from the PCT or the DCT renal tubule cells. Clinically, these are the most significant epithelial cells we see because they really do indicate significant damage or necrosis someplace in the kidney. They indicate some kind of tubular disease because that's where the cells are coming from. Thus the name renal tubular epithelial cell. So it's indicating some disease within the tubules, and then depending on where the cell comes from, the proximal, distal, or collecting duct, then you see the different shapes of cells. Does that make sense? I hope it does. If it doesn't, please see me or send me a quick note. Lots of things can cause that necrosis to happen, and there's some examples here. A lot of times it's some kind of drug toxicity or heavy metal damage. We can also see it, though, with other forms of destruction that impact the tubules and damage them. Excess hemoglobin, myoglobin, infection, all sorts of things. If we see a single cuboidal cell, I just showed you the renal fragment. The renal fragment means renal disease. A single cuboidal cell maybe means you have a little aspirin poisoning. So we're just still going to make sure. And so we're going to mention if we see a fragment of multiple cells or if we just see single ones. Renal tubular cells are known for being able to absorb things like bilirubin and hemoglobin. So you sometimes get some staining within the body. So the cells will take on a darker color. And because especially things like hemoglobin get absorbed into this, we may be able to do a special stain to see if we're absorbing hemoglobin. And that stain we talked about last time was a hemosiderin or heme, iron from heme. And we talked about the Prussian blue reaction. It's always for iron. So we can sometimes see here, these are renal tubular cells that have taken up hemoglobin. And when we did a Prussian blue stain, they turned blue. You can actually see individual iron deposits within the cells as well. So sometimes you see overall, but sometimes you see very distinct iron deposits within it. Other stuff stained as well. Let's move on from, not quite, actually, let's not move on totally yet. Let's look at just one more thing, oval fat bodies. Oval fat bodies are, I just told you that renal tubular cells can absorb stuff. They can also absorb lipids. And so oval fat bodies are renal tubular cells with lots of fat including in them that have absorbed into the tubular cell. Sometimes you can also see free-floating fat in the urine. We talked last time we met about that Maltese cross formation that we see with polarization. I'm going to show you a photograph of that in just a second. But I want to also remind you that we can always stain this urine with a fat stain called, again, either Sudan-3. Remember, Sudan in any form is always going to point you to some kind of an oil, or an oil red O stain. And that will highlight, it will only stain oil within a urine. So if it stains with the color, then you're going to know that you actually have fat bodies there and not something else. Here's oval fat bodies. So this is bright field microscopy. You can see the fat that's been absorbed into the epithelial cell. This is very small, but I left it here because the polarization was marked here. This is what we mean by a Maltese cross. You see that it forms this sort of X formation here, or if you turn it on the side, a cross formation. That's a polarized Maltese cross. We're going to see this in better detail later on in the semester, but remember that Maltese cross formation. Cholesterol will make that formation, and any kind of oils will as well. Bacteria in the urine is clinically significant because urine is typically sterile. If there's contamination, it's done during voiding of the urine. So this is a very small picture. I think in your textbook it'll be larger, but you can see very small bacteria here. Bacteria can be in the form of these bacteria as well. Either rods, these little rod shapes, or cocci, those little balls, brown balls. Rods are going to be what we typically see in a urine, though you can't dismiss if you see cocci in there. You can definitely see this. This is why, though, rods are nitrite producers that we can detect, that will convert the process to get a positive nitrite on the dipstick. Cocci do not. So this is why you can have bacteria in the urine, but a negative nitrite. You have to be able to test positive for that. So this is part of why we may do a urine microscopic if it's just not clear. Even though all of the dipstick is negative, we may see something in there that is not detected by the dipstick. Moving along, yeast. Remember, we saw a few pictures of it just a minute ago. We see it in yeast infections. A couple of different forms. We see those budding yeast, as I just showed you with the red cells. We're going to see an example in just a moment. We also have what are called mycelial cells, or mycelial forms, which are like branches. They look like branches. Typically, we just semi-quantitate them, few, moderate, many, or semi-quantitative. And I told you yesterday when we spoke, or Tuesday when we spoke, when you see sugar, yeast love to grow in a sugary urine. So patients that have diabetes, frequently you'll see them with a yeast infection. And so that's why you may also, if the dipstick is negative for everything except glucose, or if you're in a diabetic clinic like a Jocelyn clinic, they may do a microscopic on everything because they're looking to see if there's a yeast or bacterial growth there because of the sugar that flows into the urine. We also see it in patients that are immunocompromised, have other vaginal infections. We're not going to see nitrites, but we may see white cells. But be really careful. Again, if we're not 100% sure whether it's yeast or red blood cells, we're going to either stain or we can use acetic acid, lyse all the red cells, see if the yeast remain. This is that budding form. So here's the original yeast, and it forms a little bud, and then it breaks off and makes two yeast later. But buds, buds are the way they reproduce. And then this is the mycelial form, which they look like branch. So there's a little branch, it branches off, branching. And as we start to finish up here, we're going to look at parasites. The most common parasite we see in urine is Trichomonas vaginalis, T. vaginalis. It's a pear-shaped pathogen with flagella, and it really kind of hustles across the field. Let's see if I can pull up the video. If it doesn't, I'm going to send you the link to this. There we go. Great. Give me a second. And there it goes. There's the flagella, and off it goes. You saw that one hustling along, right? This one's not going too far, but oh, look at him go. There's the flagella kicking around there. So this is Trichomonas vaginalis. This is not the worst video. I was made sure not to give you one that would totally skeeve you out. We are definitely going to report these if we see them. If they're not removed, if they're not moving anymore and they're just kind of dead there, they may look like a white cell, maybe a transitional or a renal tubular cell. So you really have to, spend some attention. If you get a chance, we're going to look in just a second. You'll see they do have a different shape. Other ones, we can see schistosoma hematobium. This is not a common parasite in the United States that we don't typically see in urine. But you know what? In the advent of having the world be connected wherever we go by a plane flight 12 hours, 24 hours away, it's not impossible to see schistosoma, so we're going to take a look at it. And then Enterobius vermicularis is, we see this in its pinworm eggs, especially pinworm eggs, and we see it if there's fecal contamination typically. So let's take a look at those. There is our friend Trichomonas. This is schistosoma, has a very oval shaped with inclusions in there, and you can see how that could typically be mistaken for a white blood cell, but look at the size differential. So maybe there's a white blood cell there, and look at the size differential. It's huge comparatively. Here's a pinworm egg, and this is just also as well. Taking a look at them, you can see the pinworm eggs have a very, very distinct appearance. And you can see them. So if you see them in urine, they have a very distinct appearance. And they tend to be a little more refractory than a cell. Sperm in the urine. This can be it can be normally seen in the urine. Whether we report it or not is lab to lab dependent. If we are in a lab with a men's health clinic where maybe they're doing vasectomies, we're going to make sure we report sperm in the urine probably. If it's typical hospital lab, you may not. And we're going to do a whole chapter on sperm counts. I think it's a whole chapter, but we're going to be doing sperm counts or going over them. But basically, we don't see it a lot because urine is toxic to sperm. So they become immobile, but we see that there's a little head and a tail. Really significant. Sperm just gets expelled into the bladder instead of the urethra. The only thing that we would do, we may see this with a positive protein, and that tends to be the ways that we see it. Mucus is another sort of clinically insignificant thing. It is protein coming from renal tubular cells, maybe some glands, some squamous cells, but it takes on this very thread-like appearance. When you first look at it, you think that you don't know what it is, but you see it in urines all the time. It has a little thread. Sometimes if it starts to form, it can really be confused with a cast, but we're going to look at casts in a few minutes. Casts have a very distinct appearance that has a very regular shape to it. This does not. So, yeah, it's protein from renal tubular cells. In women especially, there's absolutely no clinical significance, but you see it a lot. Casts, on the other hand, can be normal, but they may also be clinically significant. Casts are something that, if they're formed in the urine, they're exclusively from the kidney. And where they form is in the distal convoluted tubules and the collecting duct. And they form under certain conditions, low urine flow, and usually a low pH. And so we see this under normal circumstances. Someone has someone hasn't voided for a long time. We may see this in our first morning specimen. But also if they just exercised, and you may see the protein form into a matrix that is visible in this form. Casts, as we're going to see in the picture in just a second, have parallel sides with rounded ends. We may or may not see inclusions within it. We're going to talk about all the different ones that we see. But it's really important. This is because they can be just really a protein matrix with very little inside of it. It's really important to turn that light down when we're doing, especially the low power scan. That first low power scan, I said do at least 10 fields, but more likely you could do the whole field of the urine within just a very brief amount of time. And we're also going to look around the edges of that little slide that I showed you, the COVA slide. If it's a glass cover slip, make sure you also go around the edges. Low light, totally essential, and we report casts under low power field. How is it made? Uromodulin is the protein that gets secreted routinely by renal tubular cells of the distal collecting tubules and the collecting duct. Very, very normal to low levels of excretion of this protein all the time. It gets increased with stress, with exercise, and then with some conditions. What ends up happening is the protein, while it's standing, while the urine is in what we call a stasis, a period of stasis, or it's not being flushed out of the body, especially at night, because you're not avoiding your bladder all night. The urine is in what we call a period of stasis. Acidic pH, and then in the presence of some sodium and calcium, the uromodulin protein starts to form into a matrix. And we're going to see that process in just a second. Uromodulin by itself is not typically detected by reagent strips because it's a normal protein. But if we do see cast, it's typically because other proteins from kidney disease are also being shed into the urine. How do casts form? They form within this process. So uromodulin gets excreted from the renal tubular cells of the distal convoluted tubules or the collecting duct, and they sort of start to attach to the renal tubular cells. The protein starts to build almost like a web of a network that starts to trap things, maybe some cells. Typically cells is the best thing. And more weaving of that protein happens until it forms this solid casing or matrix around the elements that are there. All of this ends up detaching from the tubular cells and gets excreted in the form of a cast. So basically, you form a little web of protein that's being excreted out of the renal tubular cells. Things get caught in it, and then it breaks off and it gets excreted. Sometimes you don't end up really catching anything within it, and you end up getting one certain kind of a cast called a hyaline cast. It's really just all protein. That's a cast. I want to make sure that I mention one other very similar thing that we see, which is a cylindroid. Clinically significant, same significance as a cast, but it doesn't take on that parallel side. Where was it? Doesn't have the parallel sides and rounded ends. What it has is a very tapered edge of one or both of the sides. It's very kind of a long string on the end of a cast, but it's clinically significant because it's really the same. Highland casts are the first ones we're going to look at. These are one of the most difficult to see. So they have a very low refractive index because there's very, very little inside of it. It's mostly all protein. As a result, you have to turn the light way down low. It's going to be colorless when it's unstained. It's that uromodulin, and you're going to use low light. What do we see, though? Do you see how the sides are parallel? And it just has a little rounding at the edge. You may get a little wrinkling on the side or something, maybe a little bit of granules, but basically they're empty looking. Let's look on. This is a cylindroid right here. See how it's parallel on the sides? But see how it tapers off to the edge? That's a cylindroid. See how it's the same? It looks the same though as a cast, right? Because they are. Normally, we can see a couple. There's very little to it. This has a little more schmutz in it, but it's still a hyaline cast. This isn't a granular cast. Very, very normally seen in low numbers after exercise, a little stress, a little dehydration, perfectly normal to see. You may start to see them in increasing numbers when you have some of these itises, glomerulonephritis, pyelonephritis, renal disease. Congestive heart failure also causes it to happen. So this is a cast. This, I kind of wish they didn't put this in, but this is a picture trying to show you that this doesn't really have a protein matrix. And what this is amorphous. It is a crystal that is laying on top of this one's probably laying on top of a cast, but no, it's attached to mucus. I'm sorry, that's what I meant to say. That this is actually a mucus thread that amorphous just gets trapped on it. But look how it doesn't have that parallel shape. Look at this, parallel sides, they're even across. This is not what we're seeing here. We have thin here, we have thicker here, we have thinner down here. This is not a cast. This is a cast formation. This one we call a pseudocast. So here we see, I told you may have a little bumps and lumps along the side. This is starting to get a little worrisome to me. They didn't seem too concerned about it, but I would be a little concerned about this, and we'll talk about why in just a second. But here's another cast here with just a little bit of stuff in it. Still a hyaline cast. Red cell cast. Remember when I told you the proteins are being released by the renal tubular cells and stuff gets trapped in it? Well, if red cells are being excreted in the urine, the red cells can get trapped. Here's the parallel side. Here's the rounded end. And oh, look at that, a bunch of red cells inside. You may get it may look very orangey because of the hemoglobin that's within there. Can be a little broken up because again, this has cells in it. So we typically, though, if we suspect a red cell cast, we're going to see free red cells as well. There's a red cell there, and a red cell there, red cell there. You don't typically see a red cell cast without red cells in the urine. Also, you're not going to see a red cell cast if you don't have positive for blood. It's going to react with the blood on the dipstick. So always look for that protein matrix around here. And you can see if we look up here, it goes right up and around like that, captured one more red cell there, and all the way back down and around. It's all embedded within that cast formation. Clinically, what does it mean? Maybe some bleeding inside of the nephron. They tend to have a more significance, more clear significance than just plain red cells. Red cells can be caused by a number of things. Red cell casts are typically seen bleeding within the nephron, glomerular damage, things like that. And again, you can see them after strenuous exercise, where you maybe are releasing some red blood cells into the urine. But we would again look at that within the context of what's going on with the patient. Interestingly enough, so we have red cell casts, and if they're sitting in urine over a period of time, the cast begins to break down. It will break down from cells to hemoglobin or myoglobin. Sometimes hemoglobin and myoglobin can damage the tissues and we end up with cast formation. But the cast ends up taking on what we call a dirty brown color. This is really from the breakdown of the cells to being releasing that hemoglobin and myoglobin. So they stain the cast with this kind of dirty brown color. In this case, if we see these dirty brown casts that are significant and considered to be more interpretive of, again, those itis diseases that we just talked about, glomerulonephritis and the like, we may want to look and see if there's any renal tubular cells there to be able to coordinate and correlate this clinically to some necrosis of the tubules. The other thing I wanted to point out in this, that the slide did really well, here's a red cell cast. There's a red blood cell, but we have all this yeast here too. Do you see the little bud off the yeast? These are budding yeast here. That's a red blood cell. So you have to be careful and look and see what you see. White cell casts, same formation process we just saw, that protein being the uromodulin being released, and it's capturing white blood cells within the protein matrix, forming a white blood cell cast. Staining may help us to determine whether it's a white blood cell or a renal tubular epithelial cast. Sometimes within the cast matrix, the cells are really packed in, and you mostly notice the granulation. But it's important that we see, again, those parallel sides with the rounded ends, because this is a cast. Do you see a cast matrix here? I sure don't, because this is a clump of white blood cells. It has no matrix, especially if you looked here, if this was a cast, you'd see the protein matrix around it, and we don't see it enclosed the way we do here. So casts are seen obviously in infections, inflammation, pyelonephritis, interstitial nephritis, lots of white blood cells, no bacteria in this case because it is it's not a bacterial infection. Pyelonephritis is a bacterial infection. Sometimes you see both red and white cell casts together, different diseases if the same disease. Bacterial casts, sometimes you see white blood cells with bacteria in it or just bacteria that get caught up in that web of uromodulin. Always make sure, again, we're going to correlate it to looking for, if we think we see a mixed bacterial white blood cell cast, I'm going to look and see if there's bacteria and white blood cells outside of the cast formations. You're going to look really carefully. Bacteria is very small, and it may start to look like granular casts. Am I going to do granular casts? I'm going to go back here for 1 second. Pardon me, I'm going to go back for 1 second. Remember I talked to you as casts are sitting in urine for a period of time, they start to, the stuff within the protein matrix starts to break down. Red cells break down into hemoglobin, and they continue to break down. White blood cells can start to break down as well. The cells degenerate within the cast formation, and instead of seeing individual cells, we just see the granules that remain. And so we're going to call those granular casts. I wish I could, I'm flipping ahead. I'm pretty sure you would think, I did just look at this. We are going to talk about granular casts in just a second. I just want you to bear that in mind, that white blood cells degenerate and can look like granular casts. And I say that because bacterial casts typically resemble granular casts. You have to be super careful to really look and see if you see a bacteria there, and you're going to see bacteria outside of the casts as well. We're going to confirm this. We can do a gram stain and look and see what kind of bacteria we have, and we see them in things like pyelonephritis. Anything can go into those protein matrices epithelial casts, especially renal tubular epithelial casts, can be found inside a matrix. And we'll see them within the cast matrix. Really, you have to be careful to look and try and distinguish them from white blood cells. I don't have a white blood cell here to reference. I think there's probably a red cell here, and there's a tubular cell. So the size differential is really, really going to be helpful in distinguishing epithelial casts. Clinically, renal tubular epithelial casts are very significant. They indicate significant tubular damage to be releasing those, or to have those renal tubular cells being caught up in a cast formation. We see it sometimes damage from heavy metals, arsenic, things like that, viral infections, drug toxicity, transplant rejections, pyelonephritis. And again, because we saw those renal tubular cells are able to absorb things like bilirubin or hemoglobin, they can take on that brownish color. The good news is that brownish color will point you towards some kind of a renal tubular. In this case, we would never think that brownish color was that dirty brown from a red cell, because that does not look like a red cell in a cast, right? They definitely look like tubular cells of some kind that have stained with bilirubin in this case. And in that case, we're going to be wondering whether the patient might have some form of hepatitis. Fatty casts, what do you think those are then? Fat, oval fat bodies stuck within a protein matrix, right? How are we going to be able to determine these? We're going to be able to do a polarized microscopy and look and see if we see that what? Maltese cross, right? Lots of things cause this: diabetes, crushing traumas, necrosis, nephrotic syndrome. But honestly, it looks like fat inside of a protein matrix, doesn't it? Look at that. Lots of little fat granules. And we'd see individual Maltese cross inside of those globules with polarization. Mixed cellular casts, red cells and white cells and tubular cells, white cells and bacteria. Any mix and match. It's your choice. Makes the identification really difficult to see. But usually you can correlate it to what you see in the urine, and maybe you may need to do some staining to see if it helps to distinguish what you've got there. And then granular casts. We're going to call these either coarse granular or fine granular. And really remember, they can come from a number of different things. Number one, the granules come either from renal tubular lysosomes, those little packets of granules that get normally excreted, can end up in a protein matrix, or the cells that we just saw, those cellular casts, start to break down and disintegrate into the form of little granules within a cast matrix. Again, here's a great cast matrix with granules. See how you don't see any cells in there? There's white cells outside, but you don't see individual cells within here. This is a granular cast. Coarse granular cast has coarse granules like this. It's hard to see here. This is probably a fine granule. You really have to focus a little bit more. And then here's bacteria, and here's those mycelium forms that we talked about, those branching forms. Granular casts start out, so let's say you have a white cell cast, it degenerates into a coarse granular cast, further degenerates, those granules continue to break down into smaller pieces, they become a fine granular cast, and granular casts continue to disintegrate until they become very, very, very fine, and the cast begins to come and take on a unique form that we call a waxy cast. This is not a waxy cast. We have a picture in just a minute. And waxy casts are always indicative of severe renal disease. This is not the best waxy cast I've ever seen. Wish I had one more. No. You notice that it looks waxy. It's very refractal. This one, I wish it had it. A lot of times you see the wax, just like you can imagine wax starting to dry out if you left it on a counter and it starts to get cracks in it. Waxy casts often get jagged edges or breaks into the wax. They called them notches. And I'll see if I can find some more pictures of it. I'm sure we'll come across some more. They're pretty identifiable on a urine, stained or unstained. But they're degenerated. And what that tells us is that they're sitting in that urine for a very, very long time, to continue to degenerate and break down and break down and break down and break down. And that sitting in the urine for a long time is telling us that urine flow is not moving out of that patient. And it's telling us the patient has renal failure. So if you see waxy casts in the urine, it's highly indicative of renal failure, because the urine isn't going out of the kidney. It's not exiting the body. It's just staying in a very static way. Broadcasts are also a renal failure cast. And the interesting part about this is broadcast means a wide cast. I mean, it's very wide. And this is almost an example. This is what I meant by that notching that we would typically see. This isn't a waxy cast, but this is that notching that you see. Broadcasts are very wide. Let's take a look at a normal cast. It's very narrow. This is because the distal convoluted tubules are narrow tubules. They're not like the size of a freeway. They're, size of a small lane. And so they're very, very small. But as you start to develop renal failure, the distal convoluted tubules get wider. They get damaged and they get bigger and bigger and bigger. And as the urine is allowed to sit there in a stasis, in that non-flowing way, and these casts are forming, the casts are allowed to form in a wider form because the convoluted tubules are wider. So it's really that damage of the distal convoluted tubule combined with the urinary stasis that ends up with these really wide or broad casts. Any kind of a cast can be a broadcast because it's not a degeneration necessarily. It's just telling us the casts are really wide. They're very, very wide. The most common, though, because again, think about it, you have that urine stasis or standing, that they tend to be things that are breaking down, like granular casts or waxy casts. So broadcasts tend to be granular like this one or waxy like this one. Bilirubin can stain it from different kinds of hepatitis, viral infections. Let's look at the crystals quickly, and we're almost done. Urine crystals are not typically significant, but we report them. We're going to see they have very clear geometric structures, and they are frequently seen from based on pH. They form in specific pHs in many, many cases. There are a few abnormal crystals, and I'll make sure to highlight those for you, that indicate liver disease or some of the inborn errors of metabolism. Some of them can be just formed within the urine from normal constituents in the urine. Some can be formed because of the way we process the urine, refrigerated it, for example, like amorphous. Some can form from, again, some of those diseases that we're concerned about. Some can be formed, they're forms of medication or treatment, iatrogenic. If you remember, I don't know if you've talked about that in phlebotomy yet, but an iatrogenic is hospital-based. So iatrogenic anemia is an anemia that we cause by too much phlebotomy, taking too much blood. Iatrogenic crystals are those formed by medications that we give, or maybe treatments with, say, radiographic dye. We tend to report these as rare, few, moderate, many, in just kind of that broad sense. Crystals are formed by precipitating out different constituents within the urine, salt, organic compounds, maybe some medication, and frequently form if the pH is either high or low, sometimes based on temperature, and we're going to see those. We get a lot of crystals forming in refrigerated specimens. And you typically will see it in something where there's a lot of dissolved solids, so the specific gravity is pretty high in order to have crystals form. How do we identify them? Shape, 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 sometimes color. The pH is highly important in this process, and we're going to show why. We're going to see normal acid or normal alkaline conditions. And sometimes we can use things like polarized microscopy to help. Sometimes we're able to do something. Temperature, pH can sometimes contribute to both the formation and our ability to get that crystal to go back into solution. For example, amorphous urates, those pink precipitant crystals that form in acid urine, happen when it gets refrigerated. All is not lost. All we have to do is put it in a dry block, heat it back up to temperature, and the amorphous urates will dissolve. Amorphous phosphates, also refrigerated, but in an alkaline urine, and this is that white precipitate. This isn't going to do anything with heat, but we can add a little acetic acid to, again, not to the primary sample, but a small aliquot of it, and see if we can dissolve some of it. Remember, we're also going to be dissolving those red blood cells, so you always have to go back to the primary specimen to check for red cells. So let's look at some of the crystals and their shapes. Amorphous urates. Urates are typically seen in a pH of an acid pH. They frequently look kind of brownish microscopically, but the sediment takes on a pinkish hue, and it's that pigment urethrin that attaches to the granules. Sometimes they get a little clumpy. You can see here they almost resemble a cast, but again, it's a very irregular shape. You don't have that nice parallel side from formation in the tubules. And so this is not a cast. This is amorphous on a mucus strand. Uric acid are rhomboid shape. This is rhomboid shape. A rhombus. There's a rhombus. They call them whetstones. I don't know if you've ever seen a stone that they use to sharpen a knife. They call it a whetstone. They sometimes say it has a whetstone shape. This does not have a picture of one with rosettes, but when we look and see, you'll see they can also form kind of in clusters. I think the book, nope, I don't have another picture of it with rosettes, but in the little handout I gave you, I believe the uric acid, there's some examples of rosettes there. Typically kind of yellow-brown. You don't know what cysteine is yet. It doesn't really resemble cysteine, other than it's a very refractal crystal. It is increased when there's purines and nucleic acids present. Sometimes we see it in patients with chemotherapy, things like that. And gout, very typically seen in gout. We should need to mention that when we do synovial fluids, we're going to see uric acid crystals forming in joint fluid. Calcium oxalate can be seen in both acid and neutral pH, so it doesn't have to be totally acidic. This is called a dihydrate, and the key feature of this, and there are multiple forms, but the one we see the most is the one that has an X in it, like an envelope. We call it an envelope shape. It has literally an X appearance through this three-dimensional shape. It's like a pyramid. When you look at it in the microscope, we'll see this a lot. It forms a pyramid shape, but remember it has an X through the square. This is the most common. We also have these dumbbell-shaped ones. This is a good dumbbell. It looks like it has a dark end here and here, like a dumbbell, or they take on this oval shape. We see this in patients that have antifreeze poisoning, and sometimes patients that get kidney stones, their calcium oxalate crystals are a big part of it. Amorphous phosphate we just spoke to. It's very similar to amorphous urates. We see it as a white precipitate, though, in an alkaline pH. We see this after it's refrigerated. Totally normal, nothing to see here, people. Other crystals we see in an alkaline urine. And I would strongly suggest that you make a list, or on that illustration that I gave you, is it an acid pH? Is it an alkaline pH? Is it a normal pH? Does it not matter what pH? I would strongly recommend that you identify which ones are alkaline and which ones are acid. So an alkaline urine pH, this is an interesting shape. We call it a coffin lid shape. And if you look at it, it's hard to see here. It's a three-dimensional, almost, I don't want to use the word pyramid, but there's a side that goes up, a side that goes up, a side that goes up, and a side that goes up into a three-dimensional shape. And it looks like, I think it's easy to see, instead of an X, this one has a Y shape with there's the arms of the Y and the Y shape. It's like two Ys back to each other in a very three-dimensional shape. They call it coffin lid, prism lid. It's usually colorless, very alkaline. We see this in UTIs often. Again, but not clinically significant, but we do report it. Calcium phosphate and calcium carbonate are obviously both calcium-based crystals. No clinical significance to either one of these. Calcium phosphate can be rectangular or little rosettes, and I believe I put that on your little picture here. Blah, blah, blah. I know I did calcium carbonate with the dumbbell. Yep. Should be, yeah, I think that's a couple of things I'd have to go back and look and see. So there's a couple of things that look exactly very similar. So I'd have to look and make sure that my list didn't have something that cross-referenced it. But they come in prisms or rosettes, which are just like little flowers, like flower petals. Calcium carbonate, this is what we see here, little dumbbell shapes. Ammonium biurate, we call this one a thorny apple. So if you look and pretend that's an apple and it has thorns off it, right? These are yellow-brown, very, very identifiable, only seen in an alkaline urine. And we typically see it in a urine that is alkaline with bacteria in it. And they form because the bacteria process the urea in the urine into biurate, and you get this abnormal crystal formation. Very, very classic. This is it's clinically significant in that it's seen in bacteria, in urines typically with bacteria, so we would always report it. You don't see it a lot though. Some of the really clinically pathologically significant crystals. Cysteine crystal, it's shaped in a perfect hexagon. So when we saw that picture of uric acid back there and it said, oh, it kind of resembles cysteine, doesn't really, because cysteine is really in a hexagon shape, not kind of a rhomboid shape. Can be thick or thin, similar sort of to uric acid, but hexagonal shape. So it's how many sides? 6, right? 1, 2, 3, 4, 5, 6 sides. This is easy to polarize, so we can definitely see it. And this is in a disorder in which you can't reabsorb cysteine. So it's obviously a clinically significant one. And we confirm this with a test using cyanide, nitroprusside reaction. We look for that. Cholesterol crystals, also significant. We frequently see them with oval fat bodies, although I don't see any here. What we see about cholesterol crystals is they're very flat plates, plates that frequently have these little notch cut out of the corner. See how the notch is cut out of the corner of that one? Has a notch cut out of the corner there. There's one that's been polarized. It has the notch cut out of the corner. So like a flat sheet of glass that has a notch cut out of it. On this one's a long notch. But so rectangular plates with notched corners. These are what we call birefringent, and it talks about the polarization process that we'll talk about when we do body fluids. We see this in some nephrotic syndromes, and we may see oval fat bodies or fatty casts with these as well. This is one of those iatrogenic things. Radiographic dye takes on a Appearance somewhat similar to crystals that polarizes in a different way. One of the differences, number one, we know a patient history. If the patient has had radiographic dye injected, that's important to know. But also the specific gravity will be very, very high with a refractometer. One of the other really significant crystals that we see is both tyrosine and leucine, two more super, super significant ones, diseases of liver disease. Tyrosine crystals are super fine crystals, very, very, very fine needles that form into kind of this clump or a rosette. We often see them with this other crystal called leucine that I will show you in just a second. This is also an inherited amino acid disorder. And so when we see this, it's highly indicative of liver disease. Leucine crystals, on the other hand, I should have done this. I wonder if I could do it without totally screwing things up. I'm not sure I can. Nope. I wanted to try and make that picture a little bit bigger. Sorry. There we go. Leucine, I did do an illustration of it on that, the crystal page. And so what it is it's yellow-brown spheres with concentric circles and then radial striations. So what that means is there's circles, and then crossing across it and out are striations or lines. I will try and get a better picture of that for you guys. But definitely it's on that illustration that I did for you in the upper right-hand corner. I just gave you one. So tyrosine is there, very, very the finest needles you can imagine. And then leucine goes with it. Two crystals consistent with liver disease. We also see bilirubin crystals. Again, notice these needles are not as fine as tyrosine. See how fine those needles are? Bilirubin crystals are still needly. They tend to clump together and they take on that typical yellow-brown that we would expect to see with bilirubin. Indicative of hepatitis, maybe some tubular damage. Good news is we're going to see a positive dipstick for that. Bad news for the patient, good news for us because we're going to be pointed in that direction by the dipstick. Sulfonamide crystals are a iatrogenic one. So this is some kind of a sulfa drug, perhaps, sulfonamides. And these take on, again, this rosette formation. These are pretty large. Sometimes they take on, like they call it a sheaves of wheat, so that maybe you don't get it in the full crystal form as the full rosette formation, but it looks like wheat that's been stacked and then clasped in the middle. This is another form of sulfonamide crystals. Usually you know something and look at the comparison side to a cell. That's not something born in nature. Ampicillin is another crystal that is needly and bundly. So there's a few things that can cause needles and bundle things, and we tend to know what someone is on when they get this. And the last things are the artifacts of urinary sediment. Fibers from material, from, underwear, meat fibers, vegetable fibers, things that are not able to be digested, fully digested. Maybe there's some fecal contamination, hair, starch, air droplets, air bubbles, pollen, diaper fibers, all sorts of things. Remember, they're going to look usually very refractal because they're not from humans. This is some kind of a fiber. This is some kind of a fiber as well. And that's it. If you have questions, let me know. I'd like you to work on those 2 worksheets that I gave you, and I will see you next after vacation. Have a good one. Bye.